Hello, we are from student group discussion B9 and we would like to present our student project results with the title of Results Abscess. These are the members of our group. My name is Dewa Putu Rajeshi Arikandini with the last 3 digits of student number 188, and I would like to start the presentation with chapter 1, Introduction. Basal abscess is a rare deep neck abscess and otitis media complication. This condition is caused by the drainage of pus through the medial wall of the mastoid processes in the digastric sulcus, resulting in the formation of a suppurative collection. The symptoms of this disease vary from symptoms of neck tissue inflammation or fever to otorrhea or facial paralysis. However, neck symptoms are the most frequently reported symptoms in patients with basal abscess. This condition is not a disease to be taken lightly, as it can lead to a life-threatening condition if not treated properly and immediately. These are the problem formulations and objectives of our student project. While the benefits of our student project are classified into 3, namely for the writers, for the institution, and for the public community.
Hello, my name is Karralika with the last 3 digit student number of 246, and I will begin the explanation for Chapter 2 Territory Issue. Part 2.1 Definition and Epidemiology of Basal Abscess. Basal abscess is a potentially lethal laterocervical or deep neck abscess from expansion of aggressive infectious middle ear and mastoid condition, across an erosion at the digastric ridge, extending far in the neck between the digastric and sternocleidomastoid muscle. Basal abscess can cause lethal complication of intracranial, neck, or even mediastinal. Therefore, it needs an early diagnosis, treatment, and surgery. The diagnosis of basal abscess is reported to be more common in males rather than in females. It also occurred more in adults than in children of 18 years and younger, with the age range of 10 weeks to 77 years. The rarity of basal abscess makes a high rate of suspicion necessary for the diagnosis. That is all from me, and the next part will be explained by my friend. Thank you.
Good morning, everyone. My name is Ledwin Meikel Wibisono with the last 3 digits of student number 061. Now I'll present about the etiology of Basil's abscess in our student project. So Basil's abscess is a laterocervical or deep neck abscess that can complicate an osteomastoiditis and provide a life-threatening risk. Basil's abscess is uncommon but can occur in people at any age. However, it usually affects the elderly. Basal abscess is frequently caused by otologic infections. It results from an erosion at the digastric ridge, which is located deep in the neck between the sternocleidomastoid and digastric muscles. This erosion is induced by an active middle ear and mastoid infectious process. That's all from me. Thank you.
Let me introduce myself. My name is Siemarga with last 3 digit of student number 134. Today I will explain about the risk factor of basal abscess. Major risk factor of basal abscess are otomastoiditis and cholesteatoma. A clinical history of otitis is commonly reported in 43% of the cases. CT and MRI are the main diagnostic tools, proving the erosion of the mastoid tip in 53% of the patients and the presence of concomitant cholesteatoma in 40% of the cases. Basal abscess is more common in adults than in children. That's all from me. Thank you.
Hello, my name is Putu Dinda Pramesti Sudastra with my student number is 130. Today I want to explain about pathogenesis of basal abscess. When the mastoid bone undergoes pneumatization, the bony wall of the mastoid bone becomes thinned. If an infection occurs in the mastoid bone, it can spread along the sternocleidomastoid muscle, trapezius muscle, and splenius capitis muscle. The bacterial infection can enter through the eustachian tube, and when inflammation occurs, there can be obstruction of the adductus ad antrum due to the accumulation of purulent secretions in the mastoid bone. That can lead to osteitis and osteonecrosis. Inflammation can also continue to spread to the inferior part and the tip of the mastoid bone, leading to erosion of the bone along the digastric ridge, including the sternocleidomastoid muscle. So that's all from me, thank you.
Om Swastiastu, doctor and friends. My name is Putu Isyundra Kesuma, last digit number 003, and today I will explain about the clinical manifestations of basalt abscess. So there are some of the clinical manifestations of basalt abscess, and the most significant is the sagging of the posterior superior external auditory canal. And the other common clinical manifestations such as neck pain, swelling in the lateral neck, post-auricular tenderness over the affected mastoid bone, atalgia, otorrhea, and also hearing loss. And one should have a high index of suspicions that the illness has progressed to nearby areas of the head and neck if any of the aforementioned are recorded and the patient appears with a fever and an accompanying leg lump. So therefore, a complete head and neck examination should always be performed. That's all from me. Thank you.
Hello, my name is Eyn Awdy Afza with last 3-digit number 102, and now I will explain the diagnosis of basalt abscess. The diagnosis of basalt abscess relies on multifaceted approach encompassing clinical assessment, imaging techniques, microbiological investigation, and audiological evaluation. Let's go to number 1, clinical evaluation. Clinical evaluation such as through medical history, physical examination, and otoscopic examination. Number 2, imaging studies. Imaging studies consist of computed tomography scan or CT scan and magnetic resonance imaging or MRI. Number 3, microbiological analysis is when necessary, abscess material is aspirated or surgically drained. Subsequent microbiological culture and sensitivity testing of the collected pus or fluid are performed to pinpoint the causative bacteria and inform antibiotic therapy. Number 4, complete blood count or CBC. The detection of leukocytosis or an elevated white blood cell count is a non-specific marker of infection and may be observed in basalt abscess cases. And the last one, audiological assessment or audiometry tests or hearing tests may be conducted to gauge the extent of hearing loss that can arise due to involvement of the middle ear and mastoid. That's all from me. Thank you.
Hello Dr. and friends, my name is Stanislaus with the last 3 digits of student ID 105. I'm going to explain about the differential diagnosis. The first one is suppurative lymphadenitis. The definition of lymphadenitis itself is an inflammation of the lymph nodes, while suppurative lymphadenitis is the inflammation of lymph nodes and is indicated by the infiltration of neutrophils into the lymph nodes. The difference between lymphadenitis and basalt abscess is that in the clinical manifestation, lymphadenitis presents as an intact lymph node that has the characteristic as mentioned before, such as liquefactive necrosis and edema, while in basalt abscess, there is a spread of purulence that extends to the node. The second one is bronchial clefts. The bronchial clefts, which occurs the most in abnormalities in the second bronchial arch malformation and least abnormalities that occurs in the first bronchial arch malformation. The difference between bronchial clefts and basalt abscess is in that bronchial clefts, mastoid is not a part of pathological process and there is no bone erosion. The last one is other neck abscess. The one type of neck abscess, which is called the Citalis abscess, occurs when pus drain from the mastoid along the digastric muscle to the cervical region. This differentiates itself from basalt abscess, which drains itself into the perivertebral region. There are other pathological conditions that may present as the differential diagnosis of basalt abscess, but those conditions are not that significantly similar to basalt abscess regarding the location, characteristic, and others. That's all from me. Thank you.
Okay, next let me introduce myself. My name is Leonyta Augustyne with the last 3 digits 150. Now I'll explain about the treatment of basalt abscess. Intravenous antibiotics should be started as soon as possible if basalt abscess is present or within the first 48 hours after hospitalization. In a few cases, according to the bacteria, cultures need to be done first in a diabetic or immunocompromised patient before CT scan. CT scan with a fluid identified requires the surgical drainage via transcervical. Fluid collection exists with a coalescent mastoiditis requiring a post-auricular incision with a complete mastoidectomy to the drainage of the deep neck portion of the abscess. This procedure is also performed with incision to dodge small damage to the greater auricular nerve, the facial nerve, and the accessory nerve. Surgical intervention such as mastoidectomy and abscess drainage is required for the effective management of basalt abscess to remove the infected tissue and prevent the spread of the infection to the other parts of the body. There are antibiotics that are appropriate for bacterial culture results, such as ceftriaxone and penicillin G. Ceftriaxone is one of the broad-spectrum antibiotics given to the patient with mastoiditis and Bisolt's abscess. Penicillin G or third-generation cephalosporin plus metronidazole are commonly given to the patient with abscess that require intensive care. That is all from me. Thank you.
Hello everyone, my name is Valerie with the last 3-digit student number of 143, and in this presentation I'm going to present about the complications of Bisolt's abscess. Bisolt's abscess, if not contained and treated properly on time, can spread to some areas in the head. Spreading of infection along the investing layer of deep fascia is very common and could lead to a few conditions, such as jugular vein thrombosis, cranial neuropathy, trismus, and superficial extension with cutaneous fistula formation. Cranial neuropathy, due to compression of the facial and vestibulocochlear cranial nerves, results in facial muscle weakness and hearing loss consecutively. Infection of Bisolt's abscess can also spread to the mediastinum, causing acute mediastinitis with a 70% mortality rate. In the long term, Bisolt's abscess could be fatal in the occurrence of sepsis or bacterial endocarditis, meningitis, and even death. That's all from me. Thank you.
Hello, my name is Nyoman Medhira, which last digit of the number is 070. Now I'll explain about the prognosis. A good prognosis for Bisolt's abscess depends on an early and precise diagnosis. Delayed diagnosis and treatment may result in problems and infection spread, perhaps harming vital neck tissues. Age and overall health of a patient are important factors in prognosis. Better result may come from having a strong immune system and general wellness. The intensity and breadth of the infections have a key role in determining the outcome. It is crucial to administer prompt and adequate care, which may include surgical drainage and antibiotic medications. The prognosis may become worse if complications like sepsis develop. This could need more thorough medical attentions and therapies. The long-term outlook is typically positive, with the majority of patients recovering fully if the infection is successfully treated and managed. So that's all from me. Thank you.
Okay, hello everyone, my name is Putu Diva Prilana Artha with 3 last digit names number 238. So I'll continue the presentation about the summary. Okay, so Bisolt's abscess is a potentially lethal laterocervical or deep neck abscess from expansion of aggressive infectious middle ear and mastoid condition, frequently caused by otologic infection. Major risk factors of Bisolt's abscess are otomastoiditis and cholesteatoma. The clinical manifestation shows the patient may have a history of chronic or recurrent otitis media with a perforated tympanic membrane and an ear that was draining. The diagnosis of Bisolt's abscess associated with chronic mastoiditis and middle ear infections relies on a multi-phased approach encompassing clinical assessment, imaging techniques, microbiological investigation, and audiological evaluation. The differential diagnosis of Bisolt's abscess, including suppurative lymphadenitis, bronchial cleft cyst, and other neck abscess. Bisolt's abscess can be treated with intravenous antibiotics in a broad spectrum with good cerebrospinal fluid penetration. The prognosis for Bisolt's abscess can be rather excellent with an early diagnosis and the right care. Okay, that's all the presentation from our group SGD B9 about Bisolt's abscess. Thank you.